If you'll be referring a lesion for endoscopic resection by another colonoscopist or for later resection by yourself, a good rule to follow is to mark the lesion on the same side of the bowel but 3 centimeters distally. You don't want to let the mark spread under the lesion because that's been associated with submucosal fibrosis and an increased risk of muscle injury and even perforation during EMR. The documentation should include a photograph of the lesion with the mark in view, and then again, note the position of the tattoo in relationship to the lesion in your report. Here's a non-granular lateral spreading tumor, an adenoma occupying about 80% of the circumference. You can see how flat this non-granular LST is. And we're going to mark this for later identification and endoscopic resection. We're going to mark this on the same side. Here, admittedly, that could be up to about 80% of the circumference, but where the lesion is centered, but back about 3 centimeters distally. And we're using the bleb technique where we first put in 1 ml of saline and then follow that with 1 ml of spot into that saline bleb. And this will keep any tattoo from getting under the lesion and inducing submucosal fibrosis. Then we take a photograph of the tattoo and the lesion, and in the report designate where we put the tattoo relative to the lesion.